Good morning, everyone. For those that don't know me, my name is Mukesh Jain. I'm the Dean of Medicine and Biological Sciences at Brown and Senior Vice President for Health Affairs. It is really great to be with you today for this annual and really distinguished event named for Ruth B. Sauber, who through her substantial contributions as Medical Student Affairs Officer for more than 20 years had a profound and enduring impact on Brown University's medical school and its students. This lectureship was established in 1994 by her son, Richard A. Sauber, alongside friends and family to pay tribute to her service, legacy, and impact with a continued goal of fostering lasting relationships between medical faculty, alums, and students. And I do want to take a minute, because we're very fortunate to have Dick Sauber and his sister Amy Sauber both joining us today. So if you just wave, sorry, I know Dick doesn't like attention, I know that. But thank you so much for being here, and I'll just take a moment to also give a special shout out to Dick, who is also the proud parent of a member of our MD class of 2026. So that'll be a big year. Each year, a distinguished Sauber lecturer is nominated by their peers in the Brown Medical Alumni Association and then chosen by the board of directors to receive this honor. The individual selected is to embody the philosophy of Brown's medical education program, someone who views medicine as a socially responsible human service profession. That can certainly be said for our 2024 Sauber lecturer, Dr. Deborah Borne, who we welcome this morning. Dr. Borne obtained her master's degree in social work at Columbia University and her medical training at Brown University and UCSF. She currently works at the San Francisco Department of Public Health. She has worked with highly marginalized communities, has been at the forefront of trauma-informed care and harm reduction in medicine, especially for populations experiencing homelessness, addiction, needing palliative care, and living with behavioral health needs. Over the past 2 decades, Dr. Borne has spearheaded research informing community-based and mobile clinical practices for people living with complex medical and social needs. And I'm really thrilled to welcome her to the stage. Thank you so much for being here.
Thank you. And I also just need to give the disclaimer, I'm still on West Coast time, so if I'm not conjugating verbs, and hi to the Sauber family. So wonderful. And it is really exciting. I do like to gab, so I have some notes, and Pooja will redirect me. The person sitting here, Pooja, was my lab partner, and we're just reminiscing 29 years ago. Okay, I'm going to cry. I am delighted beyond belief to even start to think about my 25-year career. And I usually put the MSW first because social work school was harder than medical school. Because you have to think about who you are. And do you remember the first day the dean, I can't remember who the dean was, it's like medical school is a measure of your stamina, right? And your perseverance. But I did also tell the people that I work with, my friends and my colleagues, that I'll let you know how I normally introduce myself, and I usually say, I'm Deb, I'm your doctor person. And when I found out about coming here about a month ago, I was like, how can I do this? I had to miss clinic on Friday morning, what do I do? And I do what I normally do, went to one of my advisors, who is a patient I've had since 2008. He goes by Dog on the street, and just imagine like Red Fox. Very charismatic, and I've known him from when he was housed, not housed, from use, we go back to use, and he's in a use stage, and I said, oh, Dog, I got this nomination, I can't go, I'm not gonna be in clinic. And he said, you gotta go, babe, you got this, you gotta go. And I said, well, we got this. So this conversation that we're gonna have this morning, and hopefully it'll be fun, is just about the we that I've experienced in the last 25 years. And the first, I want to start with a deep thank you. So this is a picture of Plum Village, where Thich Nhat Hanh had lived. And outside it says, I have arrived and I am home. Okay, I wasn't going to cry, and it's already started. And as somebody who's worked to help people be housed and be home, it's so beautiful to see you guys and to feel home again. All right, that's the end of the crying. I would 100% not be a doctor if it wasn't for Brown. It wasn't in the plans. I'm going to tell you the story of how I got into med school. I say I became a doctor by accident. But Brown allowed me to be me. I remember bringing Patch Adams, and then all of us got Reiki certified. Do you remember that? So our hands. I smudged the anatomy room. And they were full-on witchy in there. But I got to be radically myself at Brown, and I took that for the last 25 years. So does anyone know what that picture is on the side, that beautiful island? That's Rikers Island. So Rikers Island is a jail outside of the Bronx. You actually get to it from Queens. And about 10,000 people are there in a whole bunch of buildings. And when I was a social worker, I ran an HIV and drug prevention program early in the 90s, looking at and worked with women. And I loved my work, and I was going to get a PhD in public health. I worked for ACT UP. I ran away from the cops with needles in my pocket. It was a historical time. And my sibling died, took his life. No more crying. And you have a trauma. I was still older than all of you. And I was like, what do I want to do with this life? And I wanted to be a healer. And I thought that meant studying with an 80-year-old woman, reading tongues, and doing Mayan uterine massage or something. So I started apprenticing with an herbalist, and I loved it. And I was like, okay, I'm going to go be a Chinese medicine doctor or a naturopathic doctor. And I worked for Columbia, so I had been like 10 years since I had taken a chemistry class or something. So I started doing this post-bac program and going to Rikers during the day and like studying at night. And they wanted me to be their token alternative medicine person. This is in like 1993. There was a lockdown at Rikers. That means that the prison was closed and I couldn't leave and I couldn't go cram. And I guess I never got to meet Ruth, but I think she would probably like this story. So I had to cram, and I didn't think I did very well. So I went to go see my advisor the next day. There was like 700 people in this program, a post-bac program. And I said, I'm not going to be your token alternative medicine person, I'm sorry. And he said, well, let's go see your grades. And he took me to the director for some reason. She's looking at my grades, and she said, oh, you did really well. I was like, that's nice. She said, what do you do? I'm a social worker, yada, yada. She said, would you want to apply to our program with Brown? I said, oh, that's so sweet of you. No, thank you. I want to be a healer. Doctors are not healers. I'm going to be a healer. She said, no, we have this thing called a pleme. I'm like, pleme? The kids get in when they're like 15 years old, I don't know, out of high school. And then they become doctors, and they want older students, and they want to round it out, and you'd be perfect. I'm like, oh, that's so sweet of you. Thank you. No, I want to be a healer. She said, no, I have a really good feeling. She said, why don't you come? I never take people up there. Why don't you come? We usually just accept them. And just come up and see the school. And I met this woman, Kathy Barr, who's just amazing, who's the admissions director. And I was like, okay, I'll just apply. So I applied 1 month. You didn't take MCATs then, and I got in the next, like by accident. And then I got a full scholarship. And so your tax dollar paid for me to go to medical. Not, you weren't probably all working then, but some of you might have. And then I got a full scholarship. And I still wasn't sure, should I go and do this thing? So I did what I normally do. I went to one of my advisors, who was a woman, Diane, who had been in and out of Rikers in the 5 years that I was there. And I said, Diane, would you see me as a naturopath, or would you see me as a doctor? She said, Deb, you're an idiot. When I'm out there, I'm on the street and I'm on a run. And when I'm here, I'm going to see who they put in front of me. And I said I had to be put in front of me. But there was still one barrier more to saying yes, and that was my own internal story of not being smart enough. I didn't get into Brown undergraduate. I lost a lot of gray matter in my 20s. I chose it. It was fun times in New York City. But these kids are so smart. How am I going to be with these kids? And one of my spiritual teachers said, Deb, do you want to be smart or do you want to be wise? And what would you say? Who would be wise? She said, do not worry about being smart enough. Brown accepted you. You are totally smart enough. Think about your heart. How many times have you heard the story, Pooja? 800 times. She said, wisdom is when you take your intellect and you bring it through your heart. So a lot of this, we're going to talk about heart. I'm already over time and I got to go. My first slide. Okay. So I ended up in San Francisco for my training. I came back to the Bronx because I loved it and I worked and I taught at a residency. And then I went back again because when I volunteered as a student here in the homeless clinic, I loved it. And I wanted to work with mission-driven people and I wanted to be in front of Diane. So I ended up being the medical director of this FQHC in this crazy alley called Talmadale Health Center. And doing work at this FQHC. And I have done a lot of amazing work in San Francisco. I still can't believe I live there 25 years later because I'm a straight talker and the West Coasters are a little different. But I wanted to have a mission, and I wanted to have a human rights mission. So I want to ground a lot of what we're going to talk about today in a principle that one of my teachers talks about, Thomas Hubel, which are three fundamental portions of human rights that if we don't have them, we create trauma within ourselves and with others. And when we want to recover from trauma, we have to replace them. And one is the right to be, that we all have the right to safety. We have the right to have a place to be. We have a right to consciousness. We have a right to belong with each other. And we have a right to become. That we can co-create with the universe who we are and with have a purpose. How many people here feel like their purpose, we're all very purposeful driven. So with that, I realized in my naive way in the first years of being a medical director that I thought, if you're just mission driven, everyone's going to be great and it's going to be groovy and we're going to help these folks and everything's wonderful. But what I didn't see was misunderstood and ignored signs of trauma. And what that looks like with patients are words that many of us who are practice medicine here, like poor adherence used to be noncompliance. You're never going to use that term again. This is the last time you'll see it, please. Self-discharging from the hospital, anger, agitation, disassociation. But then I was seeing this stuff with my staff. And I was feeling this way towards my staff. I'm like, what's wrong with you people? You're here mission driven. Why are you so angry? I had inherited a clinic with the highest amount of workers' comp in the entire city. That folks it was beyond burnout. And I couldn't understand why this was happening. And it was a conversation that other directors across the country that I worked with Healthcare for the Homeless also were experiencing. And what was going on, and I had to figure it out. And it led me to learn about adverse childhood events experiences. Have anyone heard of ACEs? Has anyone? Yeah. So if you haven't, please Google this and look it up. It's already old school. The study was done in 1996 with the CDC and Kaiser. I think they looked at like 17,000 people at the time, and there's been hundreds and hundreds of thousands of people that have been looked at with the ACE scores. And ACE scores are a series of questions that ask about adverse childhood events that happen to people when they were younger, things like your parents' divorce, violence, abuse, a score of up to 10. And what they found is that those correlated with how people developed cognitively, emotionally, and it impacted their risk-taking. But there was also a correlation with disease and death even beyond people's risk. And so I'm going to just show you a few little tidbits on ACE scores here. Is that it was twice as likely to smoke if you had an ACE score of 4. I'm not going to tell you what mine is, but I definitely have one. Oops. It's 4 times as likely to have emphysema. But I want to bring your attention down to the bottom, that if you had an ACE score of over 7, you had a 360% higher chance, even if you never smoked, of having ischemic heart disease. And there's so much more research out there already. So something's going on about how we develop that impacts our health, not just with our behaviors. But there's more with trauma that we need to understand. There's psychological trauma. There's complex trauma like we see with war and with vets. I have worked with a lot of vets. There's collective trauma, like what we're seeing, what we had with COVID, what we're seeing with the Middle East. We're all impacted. There's no one in the world that's not. And then there's historical trauma, what we see with colonialism, slavery. And vicarious trauma, I'm going to take a moment just to talk about this. So as an East Coaster, I was born in Massachusetts. I was listening to, my staff would be like, vicarious trauma. I'm like, just pull up your pants and like, let's go and get your boots on. And we just suck it up. What's wrong with you? You're talking about vicarious trauma. But vicarious trauma is real, and it's a biological thing. So if I said to you, I was walking in the woods and I stepped on a snake, and then I was telling you the story, and you PET scan my brain and I PET scan your brain, Dean, our brains would look the same. Yours probably has more gray matter, but let's just say. So it happens that when you hear these stories, there's no way that's how we survived as a species, because you're not going to step on the snake now, right? You have that pattern that's already been in your brain. And secondary trauma occurs that if the Dean already had stepped on a snake, and I tell him the story, it can relive in his brain some of those experiences. So those things were happening to my staff, even though I was pretending that it just was a moral issue, that they needed to get their stuff together. But the trauma that we're going to talk about for the rest of the morning is something called sanctuary trauma. Has anyone heard of this? Sanctuary trauma is the area of trauma that we in healthcare have 100% ability and responsibility to address. And sanctuary trauma occurs that when someone who's had a traumatic experience and comes to us looking for support and is re-traumatized. How many of you have ever been to a medical provider? How many of you have ever had a traumatic experience with a medical provider? But none of us signed up for that when we decided to be nurses or social workers or doctors. So it's something that occurs, and medical trauma is a type of sanctuary trauma, and it's the number one thing that the humans that I work with, what's preventing them from having full and robust health, because it's the thing that's most alive, and it's the huge barrier to care. So there's not a minute that goes by that I don't think about the brain and the neurobiology of things, so we're going to talk a little bit about the brain, because we're just a brain with a bodysuit. And it really drives a lot of what we do. And as an addiction doctor, I think about these hormones. I just hugged Pooja a lot, and I got a lot of oxytocin. So these are the things in your brain that help you feel good. Hopefully when we're laughing, we're going to have some good feels. But the one on the all the way over there, dopamine, is the one that really is a big player. Now, I think about this all the time as an addiction doctor, but you think about it when you pick up your phone. You're on that right now, Gary. So that's actually giving you some reinforcement. Yeah.
Texting what you're saying.
Okay, excellent. So, and every time we have a checkbox and we get that to do, that's a dopamine. You eat a good sandwich, that's a thing. My patients who use cocaine or fentanyl, that gets in the dopamine. All our brains respond to dopamine the same. We just all have different things that trigger our dopamine. I let all my patients know that my dopamine enhancement is socially acceptable, my overwork, and often my overcare. So what dopamine does in our brain is it has a really robust pathway. This is your brain. And it drives patterns and repatterning. Right? So you think about, you turn on your phone or you go and like open the fridge. We have certain patterns that get reinforced by dopamine. And then the next thing that happens is if we have a trigger or a stimulus that causes a response, it goes in the dopamine pattern. And what trauma does is it limits the amount of choices that we have. It's like one way only on a highway, you don't know there's side roads. So that's what trauma does. And what the like a sympathetic nervous system makes this drive even more. Like when you're frightened and you're about to get hit by a bus, you're not going to study the Gettysburg Address, right? You're not going to memorize something because you have limited choices when that happens. But there's something called the vagus nerve from the parasympathetic system, and it's wonderful. And it helps create something, an increased heart rate variability. And what the vagus nerve can help us do is increase the space between stimulus and response and help your brain have better anticipate stress, respond to and recover from stress. Okay, so this is all happening. And what it looks like in the emotional world, because our brain goes to our emotions. Emotions are physiological things that we experience in our body. There's nothing to be scared of with the emotions. But in the red area, that's what I was seeing with my staff, right, and with the patients. And sometimes in the freeze or fawn they also use, you see when someone has hypervagal tone and they get disassociated. But where we want to be as providers, right, and I want to be right now, is in the green. I want to have joy. You want to be connected. You want to have compassion. So to get from standard care, and standard care is, what's wrong with you and some pathology, to what's happened to you, we understand that. We talked about trauma and ACE scores, to what do you want for yourself? And that's more human. But the first thing we need to do is get from standard care to trauma-informed care. Very important. And in trauma-informed care, we understand that the past can define you, and our systems aren't always there for you in the way that you want to help you. So creating trauma-informed clinical programs has been a huge part of what I've done in the last 25 years. And a lot of what I learned working with people experiencing homelessness, we used during COVID. I was the deputy of operations for COVID in San Francisco, and everyone's like, how do you know what to do? It's like, we've been doing this for 20 years. This is how we do work with our peeps. Because everyone was in a state of fight or flight, right? We all needed the same kind of tools. Pooja just told me they have mobile care now from COVID in Boston. So I'm an HIV provider as well, and we had a lot of money in San Francisco for HIV, but we didn't have 100% penetrance, meaning that there were still people that were living on the street with HIV. 16% of the folks that were the highest users, the highest cost, were living with HIV. About 9% of the people living on the street had HIV. That was much higher than the general population, and they weren't in care. And the viral load, meaning that people weren't taking meds. These were pill-only days and not shot days. So we got funding in 2013 from HRSA as part of a multi-site study. I got to be the PI and the doctor. They literally had to extract me from this program. I was a little enmeshed. And on the right is a picture of a gentleman who, there was our bracelet. We used to put them on, and so if they were stressed, they remembered that we cared for them. And the program used trauma-informed principles to address what was going on a system level, a program level, and a client level. It's now a HRSA national best practice. It's been going on. It's still going on. We've gone through a bunch of doctors. We've had 3 of the case managers have gone to be a doctor, and one of them went to Brown, and I texted him. I was like, John, are you going to be here? He's like, I'm at Yale right now working on their HIV van. So we've done incredible work. When you're in your joy, you don't know who you're going to touch. But what the program and the blueprint looked like is everyone get it together. So we had all these programs in San Francisco, and trauma looks like this. That program sucks. They don't know what they're doing. That's what trauma does. It has us othering. That's how it works. So one of the things we measured was actually how many emails we sent with that one patient that no one wants to take with 200 people on it. We measured satisfaction, how people felt about each other. And we also talked to a lot of the patients, these amazing humans that I worked with. I was like, I couldn't survive a minute on the street, right? How do you do this? And they were going from place to place to place. How do we get the program better and the system better? And we put programs together with the trauma-informed principles. I don't have time to go into it, but you can look up like how to treat each other nicely, how to communicate, all these stuff. And we put 4 programs together that worked really, really well. The homeless outreach team, this community health center where I work part-time now, the care coordination department that I've been the medical director of, and the healthcare for the homeless program. And then we got this team together, and we focused with the client as the center. But there were still outcomes that we were driving, which was take HIV meds, have a goal for your substance use, go inside, get housed. We were measuring these outcomes. These were our outcomes. And that's really important. So these were our outcomes that we were giving people. And the hypothesis we had was, is that systems and programs fail, not the people that we're serving. So this was the hypothesis, and it worked. So one of the things we needed to think about is where and how we're doing work. And I like to ask this question, is this a good location for people who have lung disease and oxygen? No, it's obvious to you, right? It's ridiculous. But from where I was standing on the streets and talking to the people I served, that's how ridiculous 4-wall clinics are for humans who have medical trauma. I want you to remember that. The systems, the buildings, the places we build, that's how crazy they are. No human in the world does not want to be healthy. No human. No human in the world does not want something for themselves. They're not failing. We are failing in the structures, literal physical structures that we're building. So this is what Home did. We did mobile care. This is Peter. He just got Nurse of the Year award. I got it in California and San Francisco. He's amazing. So we brought all the services to them, or had programs and drop-in centers like where people would go to eat lunch. I still work in one of the social service programs now. And all the clinic I do, I only work at like syringe exchange. I can't be in a four walls clinic myself. But we did outreach anywhere. Their clinic, their medical care, their visit was wherever they were. And that we used harm reduction principles, really creative, flexible, very creative plans and treatment on demand when you're ready. And that was Seth Sayotha King Thomas, one of the greatest case managers in the world. And we were dropping off some meds for a patient. And we had incredible outcomes. I want to orient you to the slide because in the study, we had the hardest to serve people living with HIV. Never been on meds, severe mental illness. And we had to, because it was a multi-site, they had to answer all the questions inside consent and do this hour-long interview in the first 2 weeks we met them. And in the 2 years of the study, 45 people could not even do that. That's how dysregulated they were at the time we met them. But the findings were incredible. So the 79% viral load suppression may not seem a lot to you, but it's the national average. So we were able to get people, these were pill days, be able to take HIV meds, most of them before they even went inside. We have a very high death rate, which is even higher after the 2 years of the study. But 86% were permanently housed. These numbers were incredible. And discharge to a standard program meant that they were able to move from mobile care to a four walls clinic. And this is fabulous. It's a great program, and it should be a model of how we do work, but it wasn't enough because who are those other people? Why were there so many people that we didn't meet? And I still see that. And the people that we didn't achieve the health goals with, our health goals, were people who had once been in the workforce and women who lost custody of their children. And 90% of the women that I work with who have had a child have lost custody of their children. We were talking about our kids. Can you imagine? So the shame factor for these human beings was triple what other patients say. I asked a patient once what it felt like. She works with me now at the health center. What did it feel like to be outside? She said, you feel so bad about yourself. I said, how did it feel about how other people felt about you? She said, it felt like a lead boot on your neck. You can feel the pressure of how society sees you. So humans that had had another identity could not move past that identity. I had a woman literally jump out of a cab on her way to get housed. So being able to receive love like I'm getting from you, like it's so great to be here, was so hard for so many folks. And every time I offered an HIV med to someone who was not ready, I was giving them dopamine of good dopamine. I was giving them shame. I was hurting these people that I loved because it was my goals, not theirs. Does that make sense? This was an eye-opener. So we started to do it was a lot of programs. I call them spin-offs. We did encampment health. We started testing in encampments. I had a lot of women that had seroconverted. They got HIV in front of my face. We started a mobile program that I work now still with HIV and with pregnancy. This is actually a picture of someone from the newspaper of one of my patients who I loved dearly, Vina. She always had a book with her, so we started, doing more of that kind of like human service work. And we started a consult service. People in other hospitals were like, Deb, we need your help. We don't know how to talk to these patients that are having so much complexity. So we started a consult service called Social Medicine in the San Francisco General Hospital, and this is San Francisco General Hospital. And one of the things that I saw in the years of the consult service, it's still going on, it's an excellent program, was that when you're out on the street, you see a look of hopelessness in people's eyes. People don't have the right to be, become, and belong, not because of who they think they are, but because of what society is seeing for them. And when I was in the hospital, I was seeing the same look, but the look was the eyes of my colleagues. And it was so heartbreaking because they didn't have what they needed to be and become and belong, that the imperative that they were being asked to do was against the human being that signed up for med school. They had these loving hearts and they couldn't. And it looked the same to me, whether the stigma and the othering and the medical trauma that you see when I was spending so much time coaching and working with other doctors. And what happens is that when you're in trauma, you get the stimulus and you have this limited response. And so, one of the things that Ruth stood for is no judgment, right? We get that we don't call that person the pancreas in room 4. But it also looks like fear. One of my friends, my best friend's daughter has colitis, and she had to do a bowel prep. And the resident came in and said, I'm so afraid that if you don't get this bowel prep right, we can't do the colonoscopy tomorrow. So we'll have to put you in restraints and put down an NG tube. She's like, you are not restraining my black daughter. We don't do that anymore. And she was so upset. I said, I feel so bad for this poor resident. He was so afraid. And she's like, you're afraid for you, you're not afraid for my daughter. And she actually talked to the attending, and the attending's like, oh my goodness, what have I done? You see, we have so much control of how we can change the conversation. That resident was responding to his fear of being good enough for his parents, not about my friend's daughter. And where I've actually gotten stuck a lot is paternalism. It's all the same mechanism, whether you call that person pancreas in the room or I know better than you what you want to do with yourself and your body. It comes out as paternalism, and it doesn't help anyone, doesn't help the patient, the provider. So I'm going to tell you a short story. This is a picture from one of our home patients that he made. The painting's like this big. He's an incredible artist, Rick, I'm going to call him. And he has HIV, lots of substance use. He's housed. His viral load's undetectable, but he also got something called pulmonary hypertension, which is one of the few things that can kill you right away. And he had done such a great job. He'd been out of the hospital. He had never been in the hospital for like a year. And I get an email from one of the doctors I was coaching, and he said, oh, I saw your guy, Rick. He's such a good guy. I think I did right by him. We wanted to admit him. He didn't want to, but we made a good plan. Why don't you read the note? And Rick comes in, and I was like, oh, my friend saw you, and yada, how did it go? He's like, that guy's an asshole. You know, no one sends you an email if they think they were an asshole, right? I said, what do you mean? He was an asshole. I said, he told me he did all this great stuff. He said, no, he was a jerk. He didn't help me. I felt worse, and I left. I was like, well, let's look at the note. And we literally read the note together. And no one writes this level of detail in the note if they don't think they did something right. Talk to patient about their meth use, because meth and pulmonary hypertension are not really, they don't do well together. Patient says he wants to continue with his meth use. Gave the patient a treatment referral. He had gotten the wrong medicine, and it hurt him. And when I talk about this and I teach with this story, it's the equivalent of hanging a bag of a potassium for someone who already has hyperkalemia. What would that do? It would kill them. So we have to understand that how our medical structure is, and even in this, even like 25 years later, and Brown was the best of med schools. We're still, our systems are set up that our brains are othering. I other all the time. I'm not perfect. And when we have this kind of mismatch, we create more shame. But there's so much we're going to do, and that's going to be the next part of our fun time together, is we're going to look at ways that we can move from a trauma-informed approach, because we have to be trauma-informed. We have to have a trauma-informed lens. We have to change structures and ways that we do the work, to a more human-centered lens, which is our, who are you? Who are you becoming, and where do you belong? Are you with me? This is important. And I'm going to start about how we do this. Viktor Frankl, how many of you have read Viktor Frankl? That's right. It's another good to-do list. You can write that in your phone, Gary. And Viktor Frankl was a psychiatrist and was in Auschwitz. And he noticed that in Auschwitz, people are sometimes the worst of themselves and sometimes the best. And why is that? And he said that between the stimulus and response, there's a space. And in that space is our power to choose our response. And in that response, that's where our freedom is. And that's where we must go with the health system. We have to start thinking about that space. And it's actually a biological space in our brain. And we have to think about how we are as providers. And what would that take? We have to go from thinking we can cure. When I'm a palliative care doctor, I feel this sense of freedom in my heart, because my only job is to decrease suffering. When I'm doing primary care, I'm like, you know that feeling, lock the note. It's this constrictive feeling. We have to move from cure to wellness, because everyone deserves to become, and belong in that wellness space. But it means that we change ourselves at a level of our identity as providers and how we get our dopamine hits. I usually, like how we get the hit of dopamine. We have to think about what that is. And the good news is that you can do it easy. When you leave here this morning and we go out and talk later, you're going to be like, Deb, I love that idea. You're going to leave with some really good ideas because I'm all about the tactical practical. Okay. And the best news about human-centered care is it focuses on you. So this cartoon I love. Thank you for laughing. I always love that you laugh. You're like the only one laughing at my jokes in med school, too. So Lassie get help, and there he is on his couch getting help. So my uncle had his knee replaced, and I think about this because I'm getting my knee replaced in a month. And he had a robot-assisted surgery. And you know in the morning they check that robot, right? I was like, but who's checking the doctor? Like, how do we check ourselves? And I'm really into this biofeedback stuff I can talk to you about later about ways we can actually check ourselves. But there's things that we can do in our day-to-day that can actually change and increase that space between the stimulus and response so that we have more than one response to things. Looking at one of my COVID friends. Okay. So, like, I don't see you in San Francisco, and I see you here. I know what's up with that. Okay. We spent many hours together during COVID. So there's 3 things we're going to look at. 3. 1, 2, 3. You got it? That's how easy it is. Gratitude, compassion, and connection. The right to be, become, and belong. And this is medicine. So I'm going to show you a quick video. This is one of my patients, and I was watching this video from this program that San Francisco has in the health department about race and equity. And this was from a film. It's a wonderful series about, if you share it, I'm going to try to, it's called Sharing Voices. And it's a wonderful series about the AIDS epidemic. And Black leaders in HIV were on this video. And there was one of my patients from this home program who was not, their data was not in that like success, 79%. They had once been a vet. They did not believe they had HIV. They were very psychotic. They were public enemy number 1. And Pat runs their own program now and actually went to Egypt on like a yoga retreat. And they're gonna kind of set the stage for what we're gonna talk about. How do I play this?
We take meds. I denied it. I didn't want to. How am I gonna have medical adherence as a homeless person who gets my shit stolen? I get my shit stolen every other day. I didn't think that it was possible. And I'm glad that I experienced that because I started to verbalize that once I started working with another clinic called San Francisco Community Health Center. And the doctor there, she touched my chakra. She was like, "You deserve love." And I was like, what in the hell? And so once she said that, that's when I felt like I had a team of people who were gonna teach me how to do this. And sure enough, that's when I was put on a treatment plan. Treating myself was not just about medication adherence. It was also about a spiritual development to love myself with these conditions.
So it's wonderful if you could hear the entire interview with them. The addiction fellows that I work with, I guess they had watched this too, and they're like, Deb, do you have a patient that you touch their chakra? And I was like, oh yeah, Pat. But I did not touch the chakra and say that at the same time. They're 2 separate interventions, so just for the record. But they were probably both true. And we can talk chakra later too. I do energy medicine and integrative health as well. So Pat talked about a lot here. But one of the things Pat showed me, and other advisors like Pat, is the first thing we need to start with is gratitude, which is the right to be. And gratitude is a great dopamine enhancer. And it's for you, not for the person that you're doing it to. This is all about you, little lassie. So it promotes action taking, and it helps you when you get new dopamine like this to make new habits, decreases stress level. It actually lowers blood pressure. And the easiest way to get your dopamine is to say thank you. My father always said thank you, and he was enhancing his own brain. And I let doctors know and other providers know, especially in the ER, this is really hard. If you go into that room and you cannot say thank you, you have 4 flat tires. We have to be able to say thank you. This is more like meditate when you turn the doorknob. No, thank you. I'm always like, thank you for coming. Like I was telling Pooja, I hadn't been to a primary care doctor in, I'm not going to say how many years because my mother's going to watch this, but a lot. Thank you. Thank you for waiting. Thank you. Can you do that? Thank you. It's so easy. Your brain's better already. That's why I thanked you at the beginning, because I was nervous. The next is gratitude journaling. How many of you keep a gratitude journal? Yeah, this is so exciting. Yeah. It's fun. You're smiling even thinking about it. So actually, in a lot of the data with the research with gratitude, journaling was actually the thing that had the most impact. And what would it look like if we actually did this in our notes? And I actually do. And some of this, I don't even notice that I'm doing, and people are like, you do this. My notes stink, and I have to lock them more. But they look like this. I'm grateful Mr. Jones is able to use his sense of humor to clearly communicate what kind of care he wants and what he can tolerate for his chronic wound. Instead of like, dude didn't want to go to the hospital. And I actually used the bottom one just recently with one of my patients. I'm so grateful that Jasmine talked to me about her drug use and we made this plan together. So that's for my brain. Gratitude. Got it? The next is compassion, the right to become. This is the right to co-create your universe. There's not one human in the entire world that doesn't want that. And compassion's been really, really well studied. It's one of the emotions that we know increases your heart rate variability. And what that does in your brain is it gets your vagus nerve so excited that it's actually able to create new relationships between your frontal cortex that lets you get new choices and your amygdala, your response. It helps that space in between, compassion. And I'm going to show this slide and tell a little backstory. So the you not enough, not believe I always use when I teach and train. And when I was putting these slides together, I found this other picture. So this is a picture of another person that was a patient, I'm going to call him Richard, who was also, like Pat, not in the 79% adherence at the time of the study. They were a farm worker, always going back to work with their family. And I'm like, where's your pills? And I was about to go on a date. And he's like, I made this for you. And this is a sweatshirt with all the things I ever said to him. I love you. You're enough. You can do this. Now, my father owned a Hallmark gift store and worked for Paramount Greeting Cards, which is in Pawtucket. And I always just thought this is what you get when your doctor stocked greeting cards for their whole childhood. Didn't affect my ACE score, or maybe it did. But those words, you are enough, are so powerful. And I ran into Pat before I'd seen this video and was like, Pat was, I was so excited to see them. And I'm like, what was the difference that made the difference? And they showed me a tattoo that said, you are love. And they said, it's when you said that to me. Now, I was just being me. I was just being Deb Borne. I was just being the person that Brown accepted. But that's where compassion comes from. It doesn't come from you being anything else. It comes from you being you. And that was the medicine. You see the difference? This is human-centered. This is medicine. I was like, take your pills. He was showing me his medicine. And I didn't get it. And now I get it. And now you get it. And so besides saying it, you must say it. You must say it. When you work with your families, Gary, just say it. You're an incredible parent. You love your child so much. Getting this award was compassionate to me. Deb, the work you've done for 25 years means something. We have to say it. But curiosity is the superpower. It is a magic wand. My teacher once said that to me. I'm like, how do I do this? How do I do this? Curiosity. Because our brains can't hold judgment. And believe me, I'm judgmental, very self-righteous. You can't hold it when you're curious. And I used to mock my friend, like, I'm wondering. But it really works. So instead of like, okay, you said you were going to get your IV. The calendar just popped up on here. See, I don't know what I do with computers. Curiosity. I'm really wondering, you said you were going to do this thing yesterday and today you can't. What's going on? Can you tell me? Do you feel the difference? you can't do this bowel prep. I'm curious. That would have been a great option for that resident, right? I'm going to send him some compassion. So that's how simple, just curious. Oh, I did it again. I'm not kidding. Okay, all right. So now we're going to talk about connection. And I show this slide all the time whenever I'm teaching. It's a rather interesting phenomenon. Every time I press the lever, that postgraduate student breathes a sigh of relief. And the addiction fellows ask me this all the time. Like, I don't understand. I'm in the room with a person, and we talk about methadone. We talk for 2 hours, and they're so excited, and then they never follow up. I was like, well, how do you look when you're doing that? I'm smiling, and we're engaged. And if they say no, I leave. Our patients want the dopamine connection, and you want the dopamine. Think about how you look when someone says yes to your treatment. And how do you look and how do you feel? This is what Pat taught me. When I finally got over, like, I got to get over my agenda. The study's going to be the study, this trauma-informed system. I need to focus on Pat. So we have to let go of what our dopamine hit is. And there's truly a power in connecting with another human being, even when it's outside of our medical treatment plan. This means QI needs to change, quality improvement, how we're measuring what we're doing, how important engagement is. We have to up-level that because that is medicine. And the first way to do it in the do-it-yourself, human-centered care that we're talking about is asking permission. I had to ask Pat permission. I know you don't believe you have HIV and you don't want to talk about it. Can I come back in 2 months and bring it up? But we're going to see you next week like we normally do. You ask permission. Is it okay if I touch you? Would you like to take a break in this interview? Do you want to practice that runtime right now? Just asking permission. Can you feel the safety? Is it okay if? These are such simple things, but whose brain is it for? Mostly for yours. It's changing your dopamine and what you're seeking from that other person, from your client, from your patient. And the last is kindness. Now, I'm so jazzed on kindness right now. I just came back from a biofeedback conference, and this a doctor, he's from UCLA. He does work, his name is Stephen, too. Maybe everyone in LA is named Stephen. And so random acts of kindness, even more than like giving yourself a spa day, decrease your inflammatory markers at the level of your genome. How cool is that? That's how we're wired. We're wired for vicarious trauma to survive, and we're wired for acts of kindness. Ruth would love that, right? That is amazing. So the easiest thing is to be kind. But kindness is not always that easy. When I was interviewed once about how can we stop othering people that are experiencing homelessness, they said, well, what do we need to do? How do we help society see people as people? And that's what I'm here for. I'm here on this earth so that we can all see all human beings as equal. Everyone deserves the right to thrive and survive, not just survive. But this guy that lived on my street for 8 years, lived on the street on the sidewalk. And I would say hi and sometimes bring him food. And I was walking down the street with my partner at the time. And they said, hi, Reg. I was like, how do you know his name? Like, I asked him. I never asked this guy his name. Now, you see how maniacal I am about human rights on the street? I did not ask this guy his name. The closer he got to my house, I started othering him. This is what our brain does. So kindness requires that we work with each other to remind each other to be kind. I cannot tell you the number of times my teams are like, Deb, turn it down. Let's be kind. You're being too direct. You need to work on it. We have to be kind to each other. And one of the things that we do in our pregnancy program, I'm going to show you and you'll see how full on woo, is we give women rose quartz hearts. This is a selenite, but I think rose quartz is in the other one. I have some too for you, Pooja, I'm going to give you. Yeah. So this is an actual rose quartz heart, and we give them to the women because 90% of our women they used to lose custody of their children. We now 70% of the women we work with go home with their babies. Really, we've changed the game. But we tell every woman what we told Pat, you deserve love. No matter what happens in this journey, you deserve to feel that. And no matter what happens with your journey with your child, you will also always love that child. And we give them the rose quartz heart. So take it home. Gratitude, compassion, and connection. How many people think they could start doing this? This is not, it's not rocket science. It's a matter, This is why social work school, this is what I learned. Okay. So I'm going to talk to you about this, love this quote. When someone called me, Amy from your department's like, why do you do this work? And why do you do social justice work? And why do you do this kind of medicine? I help people as a way to work on myself. And I work on myself to help people. That's why I'm here. I just want to be a better human being. I do care, but you don't even need to care. And to me, that's the emerging game is all about. So this is the space of human-centered medicine. We have to understand that we are the instruments of the work, and we must start with ourselves. It's not about running more and eating nutrition. It's just about how we work with our brain. And Brown saw me. You guys saw me. Pooja nominated me, saw me. And in turn, when I care for myself, then I can see others. You see how that works? Because I'm not here to other. So I'm going to end with something that I do a lot. So another thing I'm working on in San Francisco is I'm part of this trauma-informed systems initiative where we're using mindfulness, because this is a brain thing, and biofeedback through heart math as a way of actually addressing issues of racism with staff and the workforce. And I also do this with my patients. So we're going to do two parts, and you're going to join me. The first I've been doing since I worked at Rikers, okay? And the second was going to be a little deeper. We're going to do a little quick exercise. Is that okay before we end? All right. So you're going to look like this woman. It's a little biofeedback. You're just going to put your hand on your chest. You don't have to close your eyes. You can just keep your eyes open. You'll be like, what is Deb doing? Okay, this is what med school was like, right? Remember those two? The laryngeal muscle dance. Do you remember that? Okay. So you're going to hold your hand here on your heart and just notice your hand. And just bringing your attention to notice the weight of your hand on your heart. And the heat of your hand over your heart. How's that feel? That was 30 seconds. I let people know how powerful they are, that they can change their state. Now we're going to do the next part. You ready? So if it's available to you, you can close your eyes, or you can just keep your eyes open. And you can bring your breath to the area where your hand is. And breathing at any kind of rate that is comfortable to you. And if the breath's not available, just keep on feeling your hand. And breathe, bringing in one of the words that we just talked about, gratitude, compassion, connection. And now offer that word to someone that you might have seen today or someone in your life. And when you're ready, you can open your eyes. That was about as long as the video for Pat. How do you feel? So this is how powerful we are. And this is where we need to start with our medicine. Okay, I'm done. And I went over. I hope that was fun. That was what COVID was like for us, right? We did a lot of that. Another.
Slide in 2017, you said the homelessness, people got home, 86%, is that correct?
I think it's like 83, yeah.
Yeah, and then there's another thing about paternalism, and like, did I understand you correctly when you said, like, you trying to help people get a home was almost like a sign of paternalism?
Yeah, I thank you for that question. That's a wonder. I'm going to answer too, because I want to slow that down and give it some space. So, so permanent supportive housing means that someone signed a lease. So they weren't in a shelter, they weren't just put in an SRO, that they were actually had the rights to the housing, and that's what that meant. Did that answer that first part? So that's the permanent. So we worked with them. That's the magic of this program. We worked with the homeless outreach team, with the healthcare, and we worked with them over the course of it was a 2-year study to help them get into permanent supportive housing. And a lot of programs in a lot of counties have this money from the federal government, HUD, to help people to get into housing.
So there aren't enough homes for people.
There is not enough home for people. The problem with homelessness is there's not enough housing.
Yes. But how did you get 8%? That's amazing.
It was amazing. Yeah, it's amazing. Yeah. It is the cure. I had a slide in here and I took it out because I had to shorten this, that the cure for homelessness is housing. So it's a whole other talk. But I want to answer the question about paternalism. Where we get tripped up, us do-gooders, and I'm a do-gooder. Who's a do-gooder? It is the same mechanism as our brain. It just is coming out as judgment, or coming out as paternalism, or coming out as fear. You get afraid, you want to help someone, and you cannot separate the wanting to help and your response. So you give someone something that you think that they need, because you feel you cannot separate it in your body. Everyone knows that feeling. I do this with my kids, poor things. So that's what paternalism is, and it's more socially acceptable, because here I am, this do-gooder, but it's still hurting someone because it doesn't offer space for them to make the choice. And I always do their Price is Right with patients. I said, there's 3 things we can do right now. And this, the Price is Right, no wrong door. You can go to the hospital, you can take the antibiotic. I give them choices, but it has to come as an iterative, bi-directional conversation. But it's hard to get there, especially I want to just help. This is what I want to, social work doctor person. Okay.
Can you call it paternalism instead of paternalism?
I will start to do that. Thank you. I'm going to do that from now on, and I'm going to get your name afterwards so I remember that. Yeah.
Thank you. What a wonderful talk, and what I love about what you shared was just this movement from standard care to trauma care to human-centered care, and how we're really releasing the control, which is the hardest thing, because we're trained well to give the right answers, the research, we drive all these things, and you're just turning it over to the patient for this bilateral engagement that you're talking about. I think it is so human, and it's so empowering, and there's so much joy in that, I think, too, for particularly the patient. But also, I love how you brought it how we also get joy in that process as well. So that movement I'm in mental health, so moving from trauma-centered care to human-centered, I think intuitively I thought that was important, but you've actually named it and brought it into frontal cortex
That's
understanding,
great.
I guess is the best
Well,
way to put it.
thank you so much. It requires that we trust that every human has within them what they need to be whole.
Absolutely.
And that is hard to do when you're in stress. So
Yes.
it is that fundamental belief, and it's a fundamental belief that every human being has the right to be whole. So it does require those 2 things, I believe. But thank you.
As I thought about that, I know that in my practice, the way it can work is if there's enough time for the clinician. How do we create the time?
So
that-
I'll talk to you after if you want. I can talk about co-regulation, because there are biological phenomenons that occur that when our nervous system is less stressed, it actually literally changes other people. But saying thank you takes a second. That's why I pointed out the time with the biofeedback. That was 30 seconds. I do it on the street. I did it on Rikers. There's quick things we can do. I'm doing it now. So, it does require that we practice these things when we're not in a state of stress. That's a lot with the biofeedback. And it's all possible.
but I'm curious. Can we systematic?
I like that. I'm
can we-
curious. Did you notice that?
Sorry. I'm curious if there's a way we can do it system-wide, though. I appreciate the
Yes, there
small
is. We
things.
have to. We have to change our electronic medical record, the questions we ask, how we do it. We have to change our QI. We have to change how we're precepting. We have to change everything. That's what I was trying to point out. We have to. It's set. Our system is set up in a way that we're not going to succeed because it's affecting us on the neurological level. So we have to change how we're measuring, how we're talking, how we're structuring. That's why I tried to give you things that you can start to do. So I'm with you.
Thank you.
So thank you. That was a beautiful lecture. Really enjoyed it. The principles that you are describing, I think are so critical not only for clinical care, but also for clinical research.
So she was saying that. Do you want to the
Okay, can you hear me now?
Yeah.
Okay. So first of all, great lecture. Really enjoyed it. Thank you so much. The principles that you were describing are not only so critical, I think, for clinical care, but also for clinical research, going to patients, recruiting, on their terms. There's so much in here that we could do so much better in clinical development and clinical research. So, I think there's just so much to learn here. I wanted to also ask you, these principles, although they're so powerful and important, a lot of people look at them with skepticism. How do you approach a room? You have a lot of people here who are interested in this. How do you approach a room that isn't as convinced?
Ooh, I love this question. Do I have time? Okay. I think about this. If you knew truly how out there I was, you'd be like, huh. Like even when I put in my bio, I do acupuncture, but I also do other forms of healing, energy medicine and whatever. But so always know your audience, right? And we are incredible as human beings. The research around gratitude and compassion and kindness is very compelling. You can't get around the research, which is why I chose those three things. I'm very interested in biofeedback and neurobiofeedback. And there's ways to measure our heart rate variability. So we have to start using heart rate variability specifically. And I brought one of my bio markers I can show you. We have to start using it. It's better than BMI. It gives us much more data. It lets us know that our interventions are working and for ourselves. So there's definitely tools out there, and I'm not the expert, that we must start to do. And you can't get away around our neurobiology. Now, when the ACE stuff came out, it was like mind-blowing. But doesn't it feel intuitive to you? You get it, right? Your childhood stinks. Something's happened. You didn't have a right to be, become, and belong. These are principles. And you can take them from a neurobiological perspective, which I do. You can take it from a spiritual perspective. When I was at Brown, we started a program on spirituality and medicine. It was called Inward Bound. And I don't think it's going on anymore. But how do we look inside? That's what I believe. So everyone has a belief system, but you can't get away with the data. That's why we do need more research. And we need to figure out how to have the conversations, right? And get better at the conversations. I hope you're thinking differently a little than when you walked in, right? And the people in pediatrics are already kind of in this world. But it's an important conversation that you're seeing.